We want to be in parasympathetic. You ought to be in parasympathetic mode. But sadly, most people in our society are on constant sympathetic fight or flight. You know, the saber-toothed tiger is there to eat us, and we're trying to get away, versus the rest and digest parasympathetic mode. They die from all kinds of chronic diseases, heart attack, stroke, diabetes, whatever, you name it, fill in the blank, because it's all related to sleep. And what really amazes me that I learned from my patients, because I listen to them, is that as soon as I get to a certain threshold, many of them will come back and say, gee, my wife says I'm not snoring anymore. And I look at them and say, you're kidding. I barely moved your teeth.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 155. My name is Andrew.
My name is Michelle.
We are in our rental car right now, coming back from the Voices of Dentistry, headed off to the airport at 5 o'clock in the morning. And so that's why this is my morning voice right here, everyone. And we had a really, really great conference.
Yep, Voices of Dentistry.
And we're trying to share my phone as a mic, so apologize in advance for this terrible part. But we have a really great interview that does have good sound quality.
Yeah, yay!
So we're really excited to share that. It actually kind of ties in nicely with some of the things we've been talking about for the month of January with the Airway series, but it's more than that.
Yeah, I mean, it's ortho, it's pain management with our TMD patients, maybe identifying some of those TMD patients and post-ortho types of procedures that could have really jacked them up. So Dr. Hang, I actually met through Julia, I knew of him through Julia, and then he's going to have a really great course at the end of March. And actually, Cindy Johnson, who you heard on the last series, is going to be speaking at that course. So he talks about it, gives you a little bit more information at the end of the interview. So check that out, and you'll also see the links in the show notes.
So stay tuned after the interview, and we'll explain a few more things of where we're going to be next. We have some really exciting things coming up. But for right now, enjoy this interview with Dr. Bill Hang.
Hey, Michelle.
Yeah?
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So this is actually a new topic for the podcast. I took Dr. William Hang's webinar the other night, actually, and he is an orthodontist. And I was like fascinated and a little selfishly wanted him on the podcast because his topic was resonating with me from a pain management standpoint. So I'm excited to have him on again because I'm being selfish. But I think you listeners are really going to enjoy this new topic that we have not brought to you yet, which is on orthodontics. So Dr. Hang, welcome. Thank you for being here with us.
Happy to be here. Happy to be here.
You have no idea how fast acting Michelle was to get you onto this program. She listened to your webinar. I heard about it the next time. And then boom, here you are just a couple days later. This is amazing.
Well, I'm happy to do this. I've been doing orthodontics for 46 and a half years, and I was very traditionally trained and had a traditional practice where I took out teeth in definitely more than 50% of my cases. In the early 1980s, I began looking at faces, and I'd been hearing things about how orthodontists were producing temporomandibular joint problems. And it became a concern to me. And it was then that I was very embarrassed, actually, and realized that what I had been taught to do really wasn't okay. I didn't like the faces that I was producing. I was seeing the faces being sunken in, and I began to believe those who were saying there were temporomandibular joint problems associated with retractive orthodontics, and I figured out there had to be a better way. And so in 1981, I began doing a lot of continuing education and started flying all over the country and ultimately all over the world to try to find new ways. It's been an interesting journey. It hasn't ended. Back in those days, I didn't know the first thing about anything relating to airway. All I knew was that I didn't like the faces, and I was pretty sure there were a number of my patients were having TMJ problems. And I wanted to be able to prevent that and certainly not produce it. So over the years, I learned from a lot of different people and took all the courses back in the 1980s, which were on TMJ issues. And I was asked to speak at the American Academy of Craniofacial Pain meeting in Las Vegas in 2001. And I was very well accepted there. And I joined the group. And at that time, the group was almost 100% involved with treating TMJ, the pain aspect of it. But I had started becoming so aware of airway and listening to my patients. I started bringing that into what they were doing. And that whole organization started moving in the direction of treating sleep and sleep apnea. And for those who really understand it now, they understand that sleep and poor breathing are just the flip side of the TMJ pain coin. And the two are intimately related. About 5 years ago, Michael Gelb, he is the son of Harold Gelb, who is arguably the best known TMJ doctor in the 1980s in the world. Michael wrote an interesting article called Airway-Centric Dentistry. Now, in our profession, if you want to start an argument, you can talk about occlusion, and you'll find everyone want to line up with their gun against the other guy, and everyone's an expert, but nobody agrees. One thing they can agree on is we're going to disagree. And Harold Gelb was one of the best known people in the profession. So when Michael comes out and essentially writes an article which says, to be honest, all the arguments about centric relation and all those issues really don't matter. What really matters is the airway. And unless and until you fix the airway, nothing else gets fixed. That article appeared in the California Dental Association Journal a few years ago. He and I told him we need to be very specific about that. And he and I co-authored an article, which is published in the Journal of Craniomandibular Practice, which talks about the specifics of what you can and, more importantly, what you cannot do in orthodontics if you're going to be trying to deal with these issues. Now, I'm not here to say that anyone is doing anything purposely to cause TMJ problems. That is not the case at all. Nor am I saying that every time someone retracts that there's going to be an issue. The problem here is you don't know when there's going to be an issue. And we also look at the faces and we have to say, from an anthropologic point of view, why are we even retracting in the first place? If you look at the literature and you see why we are the way we are, and you look at books like an anatomist from Harvard by the name of Daniel Lieberman talking about skulls and our faces are recessed from where they used to be back in our ancestors, 10, 20,000 years ago. If you then listen to the people who are working in the sleep apnea arena and some of the biggest names, they say, gee, we wouldn't have sleep apnea if the face grew forward the way it was supposed to. When I heard that from one of the best known names in sleep, the name of Dr. John Remmers, it really resonated with me. And this was more than 15 years ago. So the point here is we've known for a long time that the face is back. And interestingly, even in one of the most seminal articles, which related to that webinar the other night that you heard me on, there was an article in the July 1981 Angle Orthodontist, which talked about class 2 malocclusion. Now, for those who are just getting into dentistry, class 2 malocclusion is classically defined as someone who has, quote, buck teeth. By that very name, saying buck teeth, you're immediately assuming that the upper teeth, quote, buck out or stick out. Well, in July of 1981, there was an article published by James McNamara, who's very well known in the profession now, talking about where the teeth are in class 2 cases. What he had essentially found using his analysis that it's pretty rare that the upper teeth actually do protrude. As a matter of fact, if the upper teeth are not ideally positioned, he found that they were often too far back rather than too far forward, which is an interesting conclusion. What he didn't then suggest was that you should move the upper teeth forward and then move the lower jaw forward, which is something that we're doing, and I've been doing since 1990. When I met John Mew in England, who's recognized this long ago. But for me, that article should have been a wake-up call for the profession to say, why are we still retracting? If the upper teeth don't really stick out in the face, why are we retracting at all? Then if you put that together with our current knowledge of tongue space and airway, and there's at least 4 articles in the refereed literature indicating that the airway can be made smaller with retraction. Why would you be doing that? There are also some articles, to be fair, which I don't believe at all, to be honest with you, and there's some flaws with them where essentially we're saying, well, it's not related. You can retract and it's not going to cause a problem. Well, that's not the patient population that finds me from literally all over the world. They're the ones who have problems. Again, I don't say that everyone has a problem, but how do you know who's going to have a problem and who isn't? And I've been reopening extraction spaces for people since 1989. I have people I quit counting at 25 states, more than 25 states and several foreign countries. I've had people come here from Australia, Europe, Africa, and
wow,
everywhere, all over Asia. I get contacted every week, or almost every day, from people who are having these issues, and they want to know, is there someone near me who can reverse this? I see on video that you're able to reverse this and help people. And I've had all those issues, and gee, can you help me find somebody? And the answer is rarely can I help them unless they're willing to and able and have the resources to come here, which is pretty sad.
So explain what you mean by you're replacing the space. So this is because people have extracted the first premolars typically, correct?
Frequently, that's part of it, but even headgear to retract, which is used without even extracting, it's designed to retard forward growth of the upper jaw. If you really read that article in 1981, you'd say, well, why are we trying to retard the forward growth of the upper jaw? It's clearly the upper jaw isn't far enough forward. And if you then have a fallback position, well, gee, we've always done it this way, I don't think that's okay anymore, because there's no evidence that no one has ever done a study showing that this is safe and effective. You're going to have a new drug introduced in the United States. You've got to prove it to the Food and Drug Administration that whatever it is both safe and effective. And to be honest, there's really little to no science in the entire orthodontic profession. As a matter of fact, a very, very interesting thing just happened this month earlier. The German government has completely stopped paying for orthodontic care. And this was something featured in the UK Telegraph. And the reason they've stopped it is because they said there's no scientific evidence that there's a long-term health benefit to traditional orthodontic care. I challenge anyone to find an article in the refereed literature that essentially says there is a long-term health benefit to orthodontic care. And I've been straightening teeth since 1972. Do I think that orthodontics could have a long-term benefit? Absolutely. I actually believe that dentistry itself should literally be at the center of healthcare. Why not? If we were in a position to really understand what's going on, and we were able to develop the upper jaw forward, and that is possible, and then develop the lower jaw forward, and that is possible, help a child establish what we call proper rest oral posture, meaning they have their teeth together lightly, their tongue to the palate, their lips together, and breathe through their nose, then we know that their faces can grow forward. And we have evidence of that. I've done it. Other people have done it. It's not secret. It's not easy. But since we can do that, we ought to be doing that. And why are we then waiting till age 12 or 13 to straighten teeth on kids whose faces have fallen back so far and they have very little facial growth remaining? And to me, honestly, putting braces on a teenager is pretty much nothing more than rearranging the deck chairs in the Titanic. We have, okay. I'm not joking. We have, I'm trying to be nice about it, but it's true.
That's the best analogy. We have currently in the United States, I believe, about 15% of the kids have been diagnosed with ADHD. And if you listen to very well-known sleep doctors like Stephen Sheldon in Chicago, who's head of Lurie Children's Hospital sleep clinic and has been at it for a long time, he says, I don't believe that ADHD actually exists. He says, I believe in every case it is a sleep and breathing problem. And yet now this number keeps creeping up. And, there's not one family member, not one mother or father that doesn't know some kid who is diagnosed with ADHD. And so essentially it would be lovely if we were treating really young kids. And what you're seeing really, if you listen to people who really know this, like Ron Harper, who's a PhD neurobiologist at UCLA, he has documented the brain damage which occurs with sleep apnea in kids.
and the number of kids who have sleep apnea is amazing. But he talks about even one night of these plummeting oxygen saturation numbers, the Purkinje cells in the brain can die, and there's damage that may be irreversible. So the more we learn about it, the more ominous it is. The American Dental Association finally this summer, I'm very happy about, came up with a position statement that dentists need to screen for this and refer. If they don't know how to treat, they need to refer for it. I happen to believe that dentistry is literally at the center of healthcare, particularly with orthodontics. We're in a position to help the face develop forward. And therefore, as the maxilla develops forward, the soft palate moves forward. As the mandible develops forward, the tongue develops forward. To the degree that both are brought back with lack of proper treatment, and we see this all the time with kids basically have very poor restoral posture. Many kids hang their mouths open, and their faces will have predominant vertical growth. And this goes back to Harvold's study on monkeys back in the 60s, where he plugged the noses on monkeys and created essentially malocclusions like we see all the time. They're not all the same, but they're out there, and the faces, the monkey's faces and teeth changed. The more you learn about it and start to, investigate, you realize there's a lot to this. And to the degree that we need to have research on ways to look earlier at kids and treat. I even treat kids in the primary dentition. I take 3 and 4-year-old kids who have been diagnosed with sleep apnea. As a matter of fact, Steve Sheldon from Chicago referred about a 4 to 5-year-old boy to me who has a failure to thrive in sleep apnea diagnosis, Pierre Robin sequence. We did our little thing of expanding laterally, but more important than that, developing the maxilla forward and the mandible forward with the orthotropics approach. We eliminated the sleep apnea. I can still remember the phone call from him. He was elated that we had eliminated the sleep apnea for this young child. The more you learn about it, you realize the failure to thrive diagnosis may well come when you're not getting into certain deeper levels of sleep, and the growth hormone is not getting secreted. So it's fascinating. And, of course, none of this gets covered, or certainly wasn't covered in dental school when I was a kid, not in orthodontic training, but it should be. I literally mean this. Dentistry is at the center of healthcare. When you understand that breathing and sleep disordered breathing and sleep apnea in particular is so prevalent, you can't ignore it. And it's related to all chronic diseases. There's really not a chronic disease that doesn't have some correlation with it. A few facts and figures. 40% of the people over age 40 snore. 60 to 80% will test positive for sleep apnea if they're tested. 95% are undiagnosed, and undiagnosed sleep apnea is good for a 20% reduction in life expectancy. Even snoring alone is correlated with plaque formation in the carotid arteries. These are all quotes that I've picked up in lectures over the years, and they're good references for them in the literature. And then when you really get to know the people in sleep and understand, they even think that the whole sleep apnea diagnosis is really kind of silly. Particularly, it misses the mark for so frequently for women, because many women will not get a sleep apnea diagnosis. To have an apneic event, to have a sleep apnea diagnosis, for instance, you have to have a certain number of times where you stop breathing for more than 10 seconds. You add up enough of those, and you say, oh, well, we had 5 or 10 or 20 or 30 or 50 an hour, whatever. Then you get the number and you get your diagnosis. Many women won't have that happen. About the time that they would have that, they have what is known as a microarousal, and they start breathing again, but they're not awake, fully awake, to be awake, like you would think, but they're really not asleep either. They're kind of in between, and they have very fragmented sleep. They awaken feeling horrible in the morning because they haven't slept well, and yet many sleep doctors will say, you're fine, you don't have sleep apnea. Well, why do I feel like garbage in the morning, like Mike Tyson beat up on me last night? Mm-hmm. It's kind of sad. The further down the road you get with this, the more you learn how prevalent this really is. And it's associated with, all the chronic diseases. People will get into fibromyalgia diagnosis, which basically is just a garbage can diagnosis. Gee, we don't know what it is, but we'll call it fibromyalgia.
Yeah. Oh, yeah.
So I hope these thoughts are kind of helpful. the next part of it is, of course, and if that's true, that the face should be forward, as John Remmers, Harvard-trained physician, very well known in the sleep arena, now retired. They had patents on many the CPAP machines and some of the things that they do. He talks about how the face should develop forward. If it doesn't, then that's why we have sleep apnea. If you talk to most people, they think it's really and even some department heads at some of the major teaching institutions, they throw up the slide. Oh, here it is in 1980. So many people are in Mississippi. They're the most obese state in the all. And they show this map every 5 years. It's spreading out, and more states have people morbidly obese, and that's what most people are focusing on. And as a matter of fact, that has a lot to do with it, but it's not the be-all and the end-all. What really it's all about is not the obesity. Obesity can easily be related to poor sleep, and there are people who know a lot more about physiology than I do who can relate how that occurs to you. We're currently seeing quite an interest in the profession about treating sleep apnea, and I view that as a good thing. The trouble is the knee-jerk reaction of the profession is, gee, we need to expand the maxilla. Well, I'm all in favor of expanding the maxilla. I've done it in my own mouth. I've reopened an extraction space that I had where I had an upper bicuspid taken out when I was 11 years of age. And 28 years ago, shortly after I began reopening extraction spaces for people, I reopened one, and for me, and put an implant in. I widened my jaw 7 millimeters, and I have a lot more tongue space. I sleep better than I did then. And I know I breathe better. But the point is, we need to have people focused on doing things which can help the problem. Everyone says expand, expand, expand. But in reality, that's not where the progress is going to be made. I heard one of the best known names in all of sleep speaking a year and a half ago at American Academy of Craniofacial Pain meeting. And he was talking about expand, expand, expand. And I just leaned over to the guy standing next to me and said, you cannot expand your way out of an anterior-posterior problem. The problem really is focused on the maxilla and the mandible being back, as most of us in industrialized societies are. And there are a number of books that have been out there, some that really dating back even to the 1800s that have recognized this. The point being, if you're really going to make progress, you need to try to develop the face forward. And for those who have been retracted back, that the podcast that you heard last week was really on how do you do that? And how can you recognize the problem? And there are simple things that hygienists can and should be doing. They can question their patient. Gee, do you awake well rested? Gee, do you tend to fall asleep while you're reading or watching television, or even in slow traffic, would you tend to fall asleep? Do you ever awaken gasping for air? And this is a very common thing. And that when that happens, most of the time someone has had an apneic event, and they may wake up in a sweat. Their body may be wet, and so their heart racing. Well, it's very likely that their oxygen saturation of their blood had plummeted a lot during that too. And so when you read that someone died, quote, peacefully in their sleep, that's the biggest joke ever. Nobody dies peacefully in their sleep. Their sympathetic nervous system is in overdrive. They've probably had apneic events going on, and they stop breathing. You'll see that people desaturate, down into the 70s. I've seen sleep reports of people desaturating their oxygen saturation to 65%. You talk to people who really know about that, and believe me, I'm just an orthodontist. I'm no, quote, real doctor here. I just learned all this on my own. You talk to people in the sleep arena, you desaturate to 65%, you may want to have your life insurance policy paid up, because that's not a good thing. Very high chance of heart attack or stroke, and that's what happens frequently to people. And yet it really isn't recognized. It's not recognized. The pain issue comes oftentimes, and you specifically asked me about that, Michelle. Let's say, particularly one of the most common treatment plans in orthodontics is what is called a camouflage treatment for a class 2 patient. And I was taught to do this. You give the child the headgear to wear, and he or she wears it, or they don't. Let's say they don't. And so the class 2 malocclusion is not getting fixed. The front teeth are not being pushed back the way you were trying to get them to. Remember, I said, I didn't want to do that. We've known from 1981, we shouldn't be doing that, but we continue to do it. So when the child doesn't wear the headgear. Oh, well, golly, no, we don't have to have them wear the headgear. We can take out an upper bicuspid on each side and we'll bring the front teeth back. And that's done all the time. And I've done it many times back in the 1970s. I will not do it for anyone anymore. What happens in those cases is you get the teeth aligned and you retract the front teeth back a little bit. And now the upper incisors touch the lower incisor teeth and they're in firm contact. In what we are taught in dental school is, a good incisal guidance position. The fact is, many of those cases still have 3, 4, or more millimeters of space remaining in the extraction site. So what's going to happen? You're paying the orthodontist to straighten the teeth. And are you going to walk out of the office with the braces taken off and a 4 millimeter gap behind your eye tooth? I don't think so. So you just close the spaces. And people are told, or they think, oh, the tongue will adapt to this. Well, not only will the tongue not adapt, the lower jaw doesn't adapt. And so as the upper front teeth are slowly brought back, they hit prematurely on the lower teeth. Now, this has been known by many general dentists have known this for years. I learned this from general dentists, not from my orthodontic training, believe me. And so if you then look at these patients, their condyles get distalized. The mandible just keeps getting pushed back and back and back. And the condyles get distalized. What happens then often, and any member of the American Academy of Craniofacial Pain or some of the other pain organizations will talk to you about how the meniscus and the jaw joint will get displaced forward and clicking and popping can start. I happen to believe that occurs very frequently. That would be a very controversial thing in dentistry and certainly in orthodontics. And you could start a good argument by having this discussion. But I think we need to have this discussion and say, gee, does this occur or not? And when I reopen extraction spaces for people, as I showed in that podcast the other day, I showed condyles which were distalized. And then I reopened the spaces and the condyles moved back forward. Now, you decide whether there's a cause and effect relationship here. Again, I'm just an orthodontist, and I'm not a real doctor here. But it makes real sense to me that there's a strong relationship here. And I know after reopening extraction spaces for as long as I have, I know when I'm going to get my hug. About as soon as I create an overjet and give the mandible the freedom, someone's going to come in and say, oh my God, the weight of the world's off my shoulders. Thank you so much. I really feel great. Typically, many of these patients where I'm reopening the extraction spaces, they'll say to me, this is great. Can you give me more space? It's almost like, a taste of honey. It's never enough. Or one potato chip. Have you ever known somebody to eat one potato chip? It's impossible. It can't even be done. But once someone has that tongue space and that airway, they long for more. I have heard so many different symptoms going away that it's amazing to me. What we're doing right now in our practice, we're trying to document these things. We're using heart rate variability measurements to document our cases. I'm working with Jeff Hinden from Suffern, New York, who has FDA-approved equipment to document the balance between the sympathetic and parasympathetic nervous system. And so we take our patient before this treatment, before we're going to have the treatment, and we take a baseline reading. We're going to see, where are they? We want to be in parasympathetic. You ought to be in parasympathetic mode. But sadly, most people in our society are on constant sympathetic fight or flight. The saber-toothed tiger is there to eat us, and we're trying to get away, versus the rest and digest parasympathetic mode. So we're looking at this. I'm not drawing any conclusions, but it's going to be part of a nice research project. And I think we need to enter the healthcare arena. I mean, if you want to see something that's really kind of sad, there was even a New York Times article a week and a half ago, which someone sent me, on orthodontics. And here it is. There's an orthodontist who's interviewed that 5 years ago, he had 100% of his patients were in fixed braces. And now 80% of them are in aligners. And he makes the statement, well, yeah, we really got to stay up with technology. And if we don't, we'll be way behind here. And then he makes the statement, orthodontists are in the tooth moving business. And I shake my head and say, really, I'm very sorry to hear that. I don't treat malocclusions, and I'm not in the tooth moving business. Yeah, I move teeth. but that's not the business I view myself as being in. I treat patients for a living, and I try to find out what's happening for them. And once we find out what's happening for them, we realize so many of them, before they even go into treatment, have symptom patterns. And as hygienists, you're in a great position to ask those questions. You're in a great position to palpate the temporomandibular joint and have somebody open. And that shouldn't hurt even minutely. You put your finger in somebody's ears and say, open, and watch the eyes. For the ones where it's really going to hurt, they're going to blink their eyes. They're also going to pull away from you. And that's not okay. Then if you want to do another thing, get a stethoscope out and listen to the joints. This is all part of a normal TMJ exam. Palpate the masseters, the anterior temporalis, the posterior temporalis, the posterior digastrics, the anterior digastrics, the sternocleidomastoid, the scalenes, and the trapezius. And then you start to get a real feel for what's going on for these patients. And you realize so many patients are already on fire. These muscles are very tender. What I've learned from my patients, and I never guarantee resolution of even one symptom for any patient. I've never said I will get rid of even one symptom for a person. My classic thing is to say, hi, I'm Bill Hang. I'm an Eagle Scout. I promise to do my best. That's it. And if you want to get into treatment with me, that's fine, but I'm not promising you anything beyond that. Now, deep inside, I've examined this patient and I know what's going on for them. And I wouldn't even start the treatment if I didn't think I had a really good chance of helping them. But in terms of promising results, that's the stupidest thing in the world. Why would I do that? There's so many different factors operating and so many different things that could cause a pain pattern. And I don't want anyone to think that, gee, Bill Hang thinks he knows all. I don't know much at all. But I do know that when I push the teeth back forward, people come back and they really thank me a whole lot.
Mm-hmm. So I have a few things that I would love to maybe just kind of circle back to just for clarification or maybe additional questions. How do you expand anterior posterior?
It's interesting because let me give the background. First time I ever tried to do this was in 1989. And there was a patient I'd seen before. She'd had teeth taken out and she had a headache going on all the time. She'd seen me in 1985 and I looked at her and I thought, she had actually had her upper lateral incisors removed and it was retracted back and she had headaches going on like crazy. And I just said, I'm sorry, I think you need to have the spaces opened. I don't know that it could be done. I can't help you. She went away and came back in 4 years. But in the interim, on all this continuing education I was doing, I'd learned about a removable appliance that you'd use when a child would have a crowded upper cuspid, for instance. You could put what's known as a sagittal appliance in, and it would move the upper front teeth forward a little bit, and the cuspids would drop in place. So I started thinking, maybe I could use that. And so for this very first patient, when she came back and she insisted I try to reopen the spaces, that's what I did. And it worked and worked very well. So I've developed a protocol, which I will be sharing at the seminar we'll discuss in a minute or a few minutes, of doing this. And it starts out with the sagittal appliances, removable appliances that are easy to wear. And within 5 months, you can generally open up an entire bicuspid width. You're not moving the roots apart. You get the crowns of the teeth apart, and then you come back with fixed braces, and you place the fixed braces in a different way than you normally would to get the roots out of the way. Now, it's interesting because one of the reasons that orthodontists remove teeth in the first place is because they've been taught that if you advance the teeth forward, you're going to cause the gums to recede and you'll cause tooth loss. That was beaten into my head really strongly. And that's one of the reasons I didn't even treat my wife until we were married for 11 years. She had crowded teeth. And here I am walking around with a woman who's my wife who's got crooked teeth, and I didn't want to treat her. But it was interesting because I decided I would treat her, and I was ready to take out second bicuspid teeth because I thought it would affect her profile less. And I got an opinion from a very well-known orthodontist who said, no, don't bother doing that. Take out the first bicuspids. It won't affect her profile, and it's technically easier. It was the best thing he ever said to me. If he'd have said take out the second bicuspids, I would have done it. I would have wrecked her face, and I wouldn't be married today because she'd have a headache all the time. She would have gotten rid of me. I wouldn't blame her. What it did for me was it made me treat her non-extraction. It made me decide she's going to be a guinea pig. I'm going to line her teeth up, and I'm not going to take any teeth out. And so we pushed her teeth forward. and that was 1982. She has no more recession than anybody else. And the point I'm going to make here is now in our refereed literature, there are at least 7 articles in our refereed literature stating that you can advance the teeth rather dramatically and not cause gum recession. And so I think we always talk about evidence-based dentistry. Well, that's great. Let's be as scientific as we can. But for God's sakes, let's look at the evidence that's already out there in our refereed literature and let's take it into account. Let's listen to it. In our course in Las Vegas, I'm going to show people and offer them these 7 articles, which were in the refereed literature, saying you can advance the teeth. Now, honestly, can you get some recession? Yeah. But I want everyone to carefully check the obituary columns in your newspaper. Check and read, does anyone die of gum recession? I've never seen it. Maybe I'm wrong and I just live in an isolated world. But the fact is, it's silly. No, I've never seen anyone lose a tooth to recession, honestly. I've seen some serious recession in my life, but that is not usually causing tooth loss. Now, if you read those same obituary columns and see what people do die from, they die from all kinds of chronic diseases, heart attack, stroke, diabetes, whatever, you name it, fill in the blank, because it's all related to sleep. And what really amazes me that I learn from my patients, because I listen to them, is that as soon as I get to a certain threshold, many of them will come back and say, gee, my wife says I'm not snoring anymore. And I look at them and say, you're kidding. I barely moved your teeth. Well, no, my wife says I'm not snoring. Well, who am I to say your wife's nuts? I'm going to listen to her. I'm listening to you. And so that's how I learn. That's why we're trying to document everything with our HRV testing, our autonomic nervous system testing, is because we want to document the physiologic change. We think we're going to see improvements in heart rate variability. The more heart rate variability you have, the better it is for you, the healthier you are. And anyone can go and do a Google search for articles on heart rate variability. It take you years to read all the articles that are out there. It's well accepted by the medical community. I believe that if we're really going to be in the healthcare profession, we need to be doing this kind of thing on our patients, because there's a lot more goes on than just those crazy teeth that happen to get crooked.
That was actually one of my questions on here, was about recession, and if there's any bone loss when you are putting these spaces back with patients.
I can show you. I'm going to show 2 patients in this upcoming seminar that are teenage patients. Very classic cases where people would often want to remove upper bicuspid teeth and pull the front teeth back, the very treatment plan that webinar was all about. And we did something very different from them, something that I came up with this idea on my own. I certainly wasn't taught it in orthodontic training. That is to literally move the lower front teeth forward. Instead of taking the upper bicuspids out and retract, move the lower teeth forward. I've done this and actually made enough space for implants to put in extra bicuspids in the lower arch. And I've not caused gum recession and tooth loss. Then I've also not only put in implants, I've had some people who didn't want to have implants. We put in temporary anchorage devices and then brought the back teeth forward to close the spaces that we created rather than put in implants. And I will show you cone beam x-rays of the bone level on these patients after we've done it. And, these patients have more bone on the labial aspect of their lower incisors than I do. And, how do I know what's going to happen between now and the time they die? I'm not going to be around when they die. They're teenagers when I treat them. The point is, it sure looks good to me now. And then I will also offer the airway changes which happened for them in the process. And one of them was a football player who had an airway that would put him in a very high risk for sleep apnea. And he got a dramatic improvement with the additional tongue space airway that we created. Again, please realize, I don't want your podcasters here, your webinar people, to think that I'm guaranteeing that someone's going to live better, live longer, or have a better airway. I can't guarantee that. Nobody could guarantee you that. But I can guarantee you this: it makes a whole lot more sense to me to move things forward. And I've got, many decades of experience doing that. When I decided back in the early 1980s that I'd either have to get out of orthodontics or, I had to quit extracting teeth. I just couldn't do it.
So can you do this with like a clear aligner, like an Invisalign or anything like that?
It's interesting. I don't want to get into that whole thing too much because I have some pretty interesting. That's a whole other subject. My bet is the answer is yes. Would I want to bother doing it? No. Many people have accused me of many things in my life, but no one has ever accused me of being patient. So when I want to do something, I want to do it and get a result in a predictable way. And so that's why I've developed a protocol. I mean, I have reopened 4 extraction spaces for a woman from Tampa, Florida, who came flying to see me. I did it in 363 days. That was a record for me. Now, this woman did exactly what I told her to do. She got the spaces opened with the removable appliances. I put the braces on the way I know I need to do to get the roots out of the way. And I got the roots out of the way. I finished the case, made the teeth fit again. And she got zirconium implants because she wanted to have zirconium rather than titanium implants. And so it was 360 days from the start to when I knew that we got our result. And normally the process takes 1.5 years. It can take as long as 2 years. I've had cases go longer than that with extenuating circumstances.
I think it's interesting because at the very beginning you said you were starting to notice people's faces and everyone had like this very typical face. And I think I think sometimes, and we talked about this on some of the Airway podcasts, like sometimes the look of a community is pretty ubiquitous, like because they're using very similar techniques on every person and not like taking into consideration
exactly
them as a person and their ethnicity and all the things. But one thing that popped into my head was when I think ortho, I don't think face. I think straightening the teeth. And yeah, okay, sometimes their face does change because of overbite, underjet, all those things, overbite, underjet. And so I think that's really fascinating because even in the results that you were showing in that webinar you did, people's faces legitimately changed when you brought them forward.
Exactly. And here we get into another thing. You got two. It's crazy. I have to, it's hard for me to maintain sanity sometimes. In the profession, you have a diagnosis of, quote, bimaxillary protrusion. Now, how do you come up with that diagnosis? Well, it's very simple. Back, I believe it was in the 1940s, a gentleman came up with what's known as the aesthetic line. You have a line from the nose to the chin.
Yeah.
And it's drawn there. And so, if the lips are ahead of that line, the face is too full. Therefore, a definition of bimaxillary protrusion, which is an interesting definition, calling it bimaxillary, since I only have one maxilla. I don't know how many maxillas you have, but there's only one. So bi meaning two is kind of silly, isn't it? Now we call it bialveolar protrusion. But when you understand the diagnosis, you understand exactly how silly it is. And then, of course, we say, well, gee, the face is too full. Let's flatten it. But it completely ignores, and I see this in the refereed literature all the time, it ignores the position of the chin. The farther back the chin is, the farther back the lips are going to be in any individual. Would that make sense to you? The chin is weak. No matter what, the lips are going to be out here. Then we get into something you touched on it, the ethnicity issue. That Caucasians have a certain length of nose. Now, I have in my practice basically a United Nations. I have people of every race you can find on planet Earth are living around here or they come here. I have African Americans. I have Japanese, Filipinos, Chinese, Vietnamese. And I can tell you unequivocally that Asian noses are at least 3 to 4 millimeters shorter. And as are African American noses, they're shorter. They're broader, but they're shorter. So those people will have fuller looking faces naturally. And that's the way they were meant to be. And trouble that here is that we're judging people on this quote Caucasian norm that someone came up with. Gee, I'd like to see flat faces. And yet, if you look at the refereed literature, the Chinese are finally recognizing this. And there are 2 articles in the refereed literature that document airway can get smaller on patients who are treated with 4 bicuspid extraction and retraction. That's from the research done in China. And I have the references for those articles that are out there. There's a lot to discuss about this whole thing, but the faces can change, and you saw it. And then what's interesting, you can't predict it either. Sometimes I do some rather dramatic movement of teeth, and the face doesn't change all that much. It's kind of amazing. There's a lot of research that's gone into how much tooth movement and how much facial change actually occurs. And basically, I would be the last person to ever predict anything in that regard. Again, that's why I always say I'm an Eagle Scout. I promise to do my best. And that's the only promise I've ever made. But I have people who, oh my gosh, they see it and they're thrilled about it when they're getting their face back. Their lips are forward. The only people that are unhappy are the plastic surgeons that don't get to do the facelifts because the lips are forward where they ought to be.
So before I start asking some selfish questions, what does a face look like that could be suffering from pain? So if I'm a hygienist and I have this patient sitting in my chair, what are some, before I even do the palpation of things, are there some things that I can look at in the symmetry and their shape of their face and how they posture to know that they're going to be have an issue?
There are, but I'm not, you learn, the longer you get into this, you learn to look at eyes, and eyes tell a terrible story, tell a story. And when you look at patients that I treat before and after, if you look at the eyes, it tells a story. Someone who's in pain, you can see it. And I don't know really how to describe it. The biggest thing is to do the muscle palpations, because that usually is a big deal. And also you ask somebody, do you get headaches? And I love this comment when someone will say, oh, no more than usual. And I say, so what is usual? Oh, 4 or 5 a week. And I look at myself and, I'm a man, and men hate pain in the worst way. That's why God set up the world for women to have the babies, because men are wusses. And if I had one headache a week, I'd view it as something pretty horrible. So I don't ever get headaches. I don't want headaches. But there are people that literally think that is part of their life. Now, my wife, for instance, you saw her previously here. She used to get 2 or 3 migraines a year, and they would wipe, one of them would wipe her out for a day. And when she'd wake up in the morning, I knew when she was going to get one. I could literally look at the color of her skin. It looked green to me, greenish skin. And I'd say, are you okay? And she'll say, oh, I'll be fine. She was never fine. She'd always, about 9 o'clock in the morning, she'd vomit, and then I'd have to take her home, and she'd sleep the entire day away, and then she'd be fine the next day. I showed you the podcast of how we moved the front teeth forward and just produced about 1.5 millimeters to 2 millimeters space on the woman who took 25 Advil per day.
Yeah.
I did that for my wife. And as soon as I did that, we're now about 6 or 7 years. She hasn't had even one migraine because I moved her front teeth forward and gave her that additional space. So the main thing is to look at the eyes, but also merely doing the muscle palpations is probably a better way. And even asking the patient, because many of them just live with pain. Often, they'll say, I get pain in the back of my neck. And they say it's because I work at a computer. And frankly, who doesn't work at a computer today? Everyone does. And they just view it as normal. Mm-hmm. You can also have somebody stand up and just look at them, look forward as if they were looking at themselves in a mirror. Now, when I take my pictures on my patients, I actually have them look at themselves in a mirror. And what you'll see is many of them hold their head forward. The middle of the ear, the tragus, when someone's standing straight up, that should go right, perpendicular to the floor, should go right in the middle of their shoulder. If you have someone stand up, you look at them from the front. They'll often be, one shoulder will be lower. These are things to do. But if they have forward head posture, frequently their cervical muscles are paying a price for that. Another thing is that if they're looking in a mirror, they're looking straight forward at themselves. Look at the slope of their forehead. How far back does their forehead tilt? The forehead, believe it or not, should be vertical. Now, you're hard-pressed to find one of us in industrial society that has a forehead that's very close to that. Most of us will have our head tilted back a little bit because of it.
Andrew and I are trying to do our profiles right now.
Michelle, yours is more vertical than most people. I have a gentleman who just came to see me, right? He just flew in here 2 days ago from London, England. He's got horrible sleep apnea. He's had surgery to his 6th cervical vertebrae. He has lower back problems, and he's basically disabled. For him to even sit up like this is painful. He can lay down, but he can't take the weight of his head on his shoulders. The fact is, he has massive forward head posture, and his head is tilted back like this at perhaps a 35 to 40 degree angle. He looks like he's been down to Cape Canaveral watching a rocket go up when he's just looking forward. That's what he has to do just to breathe. And with his head in that position, he has an airway that in cross section is so small that when I look at it, I shake my head and said, yeah, he's got sleep apnea. And again, the trouble is that the exact size of the airway is not diagnostic, but he knows he has sleep apnea because he's had a test and he knows that. So looking at the way someone holds their head is a way to know. And the farther forward that head is off of center, the more likely the person is to have cervical pain. Now, again, as dentists, we got to be really careful about what we're promising somebody. Our arena depends on the state of licensure you're in, with licensure, it's the teeth and the surrounding structures. But, why have we made these artificial limitations to what we do just because we're dentists? The teeth actually, amazingly, they're actually a part of the body.
Stop it.
I know. I know that's heresy, isn't it?
So I think Andrew and I both want to be diagnosed. Because the thing, like I said, I was being very selfish when I brought you on because I have had condylar degeneration, like I mentioned. I've had orthodontic surgery with mandibular advancement, but I've also had about a strong 10 years of ortho. And pretty much from 5th grade to 9th, I had headgear. Like,
oh, wow.
And aggressive headgear.
Yeah, no, and you were a good girl and you wore it. Am I right?
Oh yeah.
We always, when the kids come in and they say, "Oh, I was given a headgear to wear," and they say, "I didn't wear it," we say, "Congratulations." Now, of course, I grew up in a family where I didn't want to do anything wrong, and I would have been like you. I'd have worn the headgear really well. If some guy with a white coat told me to do it, well, I would have done it. But what you have to understand, think about this. Look at it from a physical perspective. What really happens here? Let's talk about how you got where you were. Why did you need that mandibular advancement surgery? Because your mandible went back. It's really interesting. I have pictures of a girl from aged 8 to 16. She wore a headgear. And with every few years going by, every couple of years, here are the pictures, her lower jaw is back further and further and further. Think about it. You wore a headgear that was attached to your upper molars. Am I correct?
Correct.
Yes. Okay. That headgear has a distalizing force, but it also has a vertical force on your upper molar. And you could do the physics and see what the vector is, how much of the horizontal vector, how much of a vertical vector. But what you're really doing is driving a wedge between the back teeth. Would that make sense to you?
Mm-hmm.
Okay. Think about what happens to your mandible as the upper molar, if it moves back 1 millimeter and down 1 millimeter. The mandible has to go like this, doesn't it?
Yeah.
Okay.
Hinge forward.
Then that makes the class 2 malocclusion actually look worse. And then you go to the orthodontist and he's seeing the malocclusions getting worse. So then he says, Michelle, you got to wear the headgear more. And so here you are, you're wearing the headgear 26 out of every 24 hours. And he still says it's not enough. And you wear it and wear it and wear it, and it's getting worse and worse and worse. I call that, and I have a nice little article or thing in my lecture, I call that the dog chasing the tail. Essentially, you're going faster and faster, and it's down and back. Now, I don't want to get into what I think happens to the jaw joint. I don't think doing anything like that is helpful to the joint. If I wanted to start a controversy about this and have myself in really hot water, we could go making all kinds of claims. I'm not here to do that. To me, it just makes no sense to do it from an aesthetic perspective, given the fact that the refereed literature told us 1981 that the upper teeth don't stick out. Why the heck do we want to shove them back? So you then had your mandible back and back and back. The disc went out, and my bet is you get clicking and popping, and probably you've got some nice scratchy sounds going on there. We call that crepitus. And you had the mandible advanced. Your disc was probably out of place when it was done. You didn't have the maxilla advanced. And if I would have done your case, I would have advanced the maxilla as well, because in every class 2 case, and I say that, the maxilla isn't where it ought to be. You need to bring it forward. And I talk about in the session we're going to have in Las Vegas, how do we diagnose the position of the jaws in the face? We're going to talk about that. If I were going to treat you, I would advance your maxilla, advance your mandible, and I would have a surgeon who's going to look very carefully at the status of your jaw joint. If the disc is clicking and popping, There's an article in the refereed literature that if that is ignored, there's a 75% or 74% chance, I believe it is, of you having problems down the road and maybe even having to have a total joint replacement because of condylar resorption, which is the last thing that anybody wants to have happen. But these are things that need to be looked at. And the fact is the outcomes, go on the internet and you can see that the outcomes of orthodontic surgery, there's a lot of poor outcomes. And it's true. They're not lying. They're not happy. But the point is, that people are doing the surgery well-meaning, but they're ignoring the health of the jaw joint in the process. Orthodontic surgery, we'll be covering that in the seminar. We'll touch on that to some degree, what you have to look for and how can you optimize facial balance, airway health, and temporomandibular joint health. I have a slide that I'll show that those three things are tied for number one. I can't isolate one of them. They're all of those things. That's a given. And then I have these things tied for number one, and then the next number is 27. That number 27 is, oh, by the way, I want the teeth to fit. I make it that way because I assume that the surgeon is going to make the teeth fit. But that's the least important thing for me. If I have the other things, then I know that the joints are happy and the patient looks good and the patient breathes well too. And that's all critically important.
So can you tell us a little bit more about this seminar that you're going to be having coming up soon? I believe it's March, correct?
Right. It's March 22nd and 23rd in Las Vegas. And it's basically going to be on non-retractive orthodontics. Again, I told you I get people from all over the world contacting me from Cambodia, Kathmandu, Nepal, Korea, Japan, Africa, wherever. Gee, do you know someone in my town, get that, who can reopen my spaces for me? And I say, no, I don't even know anyone in your whole continent I could send you to. Sorry. But my goal is to teach people how to do this. I'm not telling you I know everything. I sure don't. But I'm going to offer what I've learned from my patients and in the process of basically, I've been in 50 states and more than 30 some foreign countries trying to learn what I do. And I want to share that. So we're going to talk about how can you treat people and hopefully not do these problems? How can you treat people who have horribly crowded teeth and align their teeth for them if that's what they want and not take the teeth out? I'll show cases that are incredibly crowded and I've aligned the teeth and there's no recession, none whatsoever. I'll show you their airways as well. I'll show you their facial balance. We'll show you treating patients who have class 2 and how do we treat them and get rid of their overjet without retracting. I already alluded to that earlier. We'll show some of those cases. Going up the ladder here in more complex things, we'll talk about how do you diagnose some of the pain patterns and how do you know someone has a problem and how do you treat the person who's had the teeth taken out. We'll contrast upper bicuspid extraction cases and fore bicuspid extraction cases and how they're different and why the orthodontist made that decision in the first place. We're not here to badmouth the profession. We're here to say enough is enough. We know enough today that we can't do this anymore. We see these patients. We have to find a better way. And that's what I'm trying to offer. What makes sense to me. We'll show the specifics of reopening extraction spaces. I'll show essentially as closest I have to a cookbook protocol. The biggest message here is that it takes a team of people to do this. You have to have an orthodontist who's made the decision that he doesn't want to retract anymore and who is wanting to reopen extraction spaces for people and make some people seriously happy in the process. That orthodontist should have the technical ability to look at what I'm doing and the variations on traditional mechanics that I'm going to show to be able to walk out of that room and hopefully go back home and start, know how to diagnose the cases, know when it's going to be successful or when you think it's going to be successful, and when would that patient require surgery, for instance. And we got to get over this whole thing that surgery is radical. To me, dying early is radical. I don't want to die early. I want to be around to keep my wife totally miserable for as long as possible. and if you ask her, I do a good job. She's been around for 47 and a half years. She must like it. But the point is, I want to be there for my grandkids. And you've already had orthodontic surgery. Particularly when you do surgery on patients who have sleep apnea, they literally, and I've had more than a dozen cases done surgery since September, and several of them have come and said to me, "You've saved my life." And I mean it in those words. We're going to show that kind of a thing and help people understand how to diagnose and how to form teams. We're going to have an implant surgeon who is going to show how he can place implants when I've barely given him enough room to do so, because getting the roots apart can be very challenging in these cases. I'm going to have a restorative dentist who can take these patients that have had me reopen the extraction spaces. And many of them have beaten their teeth up because they've ground and clenched and ground on their teeth, and they've got severe wear. When I'm done, they've got space for implants, and they've got ugly, awful teeth that are lined up that look like someone took a file to them, and they're not attractive. I have a restorative dentist who can restore them and give a person a very youthful smile. And you saw 2 cases on that webinar where that was done by this dentist, who can then make sure all the muscles are happy and not mess up what I've done by trapping the lower jaw and producing an occlusion that makes the mandible trapped. So she'll speak for 45 minutes. The implant surgeon is going to speak. Rob Weiss, who is the owner of Space Maintainers Laboratories and knows a ton about sleep, he's going to speak at the meeting and put the whole thing in overall perspective. You see how sleep and breathing are huge issues. You can get courses on sleep all the time now. And Rob has a lab where he makes sleep appliances, but he's going to be the first to tell you that they're a Band-Aid. That's what he's going to say. Sleep appliances are a Band-Aid. Then we're going to have 2 other people who are experts in marketing, so that here you are, you can know how to market this in your practice. And when you develop the team, then you have the people who can work together to make this thing happen. You have an orthodontist usually, or a general dentist doing orthodontics, who can open the spaces, an implant surgeon, a restorative dentist. Maybe there are other ancillary people. Myofunctional therapists should come. Hygienists should come. Hygienists should come with their dentists. Hygienists should come because they're the ones who are the point people here to be diagnosing the problem in the first place. So that's what the seminar is about. And we're looking forward to having lots of people who really want to make a difference. From a selfish perspective, this is something that's going to be beneficial for fee-for-service dentistry, because people who willingly pay money to have this done because they see the benefit. It's not about, gee, I got a nice looking crown on my upper incisor. It's about, oh my gosh, I'm feeling better now, I've got my life back. A lot of stuff, and we'll go into all of that kind of thing.
That sounds all amazing. And where can they find more information?
Orthodontics and OSA.com will give them information on how to register for the seminar.
And we'll have that in the show notes as well. You can also head over to our Instagram account, because we have put some information about the course there as well. And thank you for all of this information. This was, again, Andrew and I both, we're probably just going to come to your office.
Yeah, we're going to have to do round 2 for sure on the podcast, and then both be patient.
Okay. Well, so nice to talk to you, and thank you for giving me the opportunity.
Awesome. Thank you.
So it blows your mind every time, right? Like every time we come out of these interviews, you and I were on this nerd high after this, right?
Yeah, no, it was a solid day for us, that for sure.
Yeah, so we knocked out a bunch of interviews, and this kind of like finished it up, and we were just like, oh my gosh, this is crazy, this information. And what he's doing for his patients is really crazy. And we both obviously need a consult.
we were talking about that as like, well, maybe we could be like test patients. We can document all this for a mini docu-series of sorts, because that would be kind of fun.
I know. It's hard to talk to these people and not like selfishly look inward and see how jacked up you are.
That's pretty true.
So thanks everyone for listening. If you want to reach out to us, you can reach us at ataleoftwohygienist@gmail.com. We are loving the interaction on Instagram and Facebook. I hope everybody enjoyed the little footage that I got from OSAP, the infection control course. And you can actually head over to our Instagram account, because we're doing some things on Instagram TV, little interviews, so you can always get that information there. And then you can also head over to our website, ataleoftwohygienist.com, where you can subscribe in our email list, because I swear we've said it for a little while, but we really are going to do something cool, and it's coming soon. So stay tuned for that.
And if you guys want to see us in person, we're going to be at Yankee this weekend coming up. by the time this releases, we'll actually probably be at Yankee. So come find us. Probably instant message or direct message us to find out exactly where we are, because we are going to be kind of all over the place with meetings and interviews and things like that. So do that. And then we have some really amazing episodes coming up. We kind of alluded to it last week. Some just very nerdy, awesome hygiene-related goodness. So tell your friends and get ready for that.
Yep. And have a great week, y'all.
Bye, everyone.
Bye, y'all.